Welcome everyone. Good afternoon. I'm Cynthia Minkovitz, and I'm chair of the Department of Population, Family, and Reproductive Health, and I'm delighted to welcome you to today's seminar, which is jointly hosted as a part of a series that PopFam is offering with the Division of Cardiology at the School of Medicine. Today's speaker is well known to many in our audience, and it's my real honor and pleasure to introduce Dr. Wendy Bennett. Dr. Bennett is Associate Professor of Medicine in the Division of General Internal Medicine here at Hopkins, and she holds joint appointments at the School of Public Health, both in our department in Population, Family, and Reproductive Health and in Epidemiology. Dr. Bennett also wears many hats at Johns Hopkins University, and so you may have worked with her, encountered her in some of these other capacities, and I'll just list a few. She's a practicing general internist at Johns Hopkins Bayview, and she's also director of research at Johns Hopkins Community Physicians. She co-directs the Center for Women's Health, Sex, and Gender Research, and she also directs the Career Enhancement Core of the Johns Hopkins Specialized Center of Research Excellence, known as the SCORE, on sex differences. She's core faculty, I'm very pleased to say, in our Center of Excellence in Maternal and Child Health, and also at the Welch Center. By way of training, Dr. Bennett earned her master's in public health and her MD from Rutgers University before we were fortunate that she got wooed to Hopkins, where she completed her residency in general internal medicine in the primary care track at Bayview. And then she stayed to join the general internal medicine fellowship in clinical research before joining the faculty. I'm so excited about Dr. Bennett's research, which is focused on the prevention of diabetes, obesity, and cardiovascular disease, especially among high-risk groups of women. She's particularly interested in sustainable models to improve health behavior change and chronic disease prevention, care access and quality, and to focus on health equity. And as such, she's keenly interested in the work that she does in the translation of research to practice. Today, she's going to share some of her really exciting work around a pragmatic clinical trial that focuses on limiting gestational weight gain and preventing obesity, and importantly, bridging the gap between randomized trials and clinical practice. So thanks so much for joining us today.
Great, thanks, Cynthia. That was lovely, and it's good to see everyone here. Lots of friends here in this department. And we talked about before everyone joined that I'm happy to take questions as we go, so feel free to put them in the chat, although let me make sure I can see that, or if I'm not seeing the chat quickly enough, you can maybe raise your hand or come off mute. So, and I think we should have time for questions at the end. So as Dr. Minkovitz said, I'm going to talk about a trial that we had funded, now we're in year 3, to talk about this pragmatic clinical trial focused on limiting gestational weight gain, ultimately to prevent obesity. And we're going to think about randomized controlled trial design, but also that pragmatic piece is a big focus of this. Okay, so the first is having us think a little bit about what is the evidence base right now and what's the rationale for designing pragmatic randomized controlled trials focused on weight gain in pregnancy. And then I'm going to share with you the design of our trial. And I'm going to talk through, for those of you that want to be clinical trialists, I think this should be helpful to think about some of the principles and guidance. So what are the things we have to consider about pragmatic randomized controlled trials to make them real world and to make them applicable to potentially clinical and other public health settings. And I'm going to highlight some of the features and challenges specific to our trial and then give you some next steps. So I am a primary care doctor, as Cynthia highlighted, so I always start with patients. And this is a patient who I'm sure will be very familiar to all of you because not an uncommon situation. So this is LR, and she just delivered. This was her 3rd pregnancy, and she fortunately had a healthy baby boy. She delivered by cesarean delivery at 36 weeks, so a bit early. And the reason she was induced and delivered early is she had severe preeclampsia at 36 weeks. She had also been diagnosed at 24 weeks gestation with gestational diabetes, and she did gain too much weight in pregnancy. She gained a total of 34 pounds up until 36 weeks, and she came in already with pre-pregnancy obesity with a body mass index of 37.2. Notably, she had a good support system. She was working through her pregnancy. She was Medicaid eligible, lives with her partner, two other children, but she really hadn't had any care in a long time prior to this pregnancy, and she did not have a primary care provider. So I want to highlight some of the what we know about obesity. And obesity really disproportionately impacts women, particularly African American women. And we always get this data sort of updated, but this is data through 2016. And you can see that this is looking at obesity defined as a body mass index greater than or equal to 30. And you can see that it's increasing in women. But way at the bottom, you can see the prevalence among Black or African American females, and it is very high, so about 54% in 2007, 2010, and then it actually went up in 2013 to 2016. So there's a lot of disparities associated with maternal obesity, and we know that maternal obesity is a cause for increasing disparities in maternal morbidity. So in 2015, half of all women entered pregnancy with overweight or obesity. African American women were much more likely to enter their pregnancy with this as a risk factor. And then they also, on top of entering pregnancy with overweight or obesity, they are more likely to gain excess weight in pregnancy. Maternal obesity and excess weight gain are associated with many risk factors. So we know that they're associated with pregnancy complications. And I mentioned in the case that she had both gestational diabetes and preeclampsia. But as a general internist, someone who takes care of women and men, I've been really interested in chronic disease prevention, and gaining too much in pregnancy is associated with future obesity, and it's associated with chronic diseases that are related to, that we know are related to obesity, like diabetes and heart disease. So this came out many years ago now, in 2009, where at the time the Institute of Medicine came out with guidance saying how much should women be gaining in pregnancy. And for the first time, they based their recommendations on pre-pregnancy BMI. This at the time was all based on expert opinion, but since then it has been tested in multiple trials and shown to probably be the best evidence and guidance for where we let women know clinically where the range is that they should be targeting in pregnancy. What's also important to know about these guidelines is this was really the first time that they thought about overgaining in pregnancy. And prior to this, all the guidance was really focused on how to get women to gain as much weight as possible, because there was a lot of concern about inadequate weight gain. So it's important to look at these ranges. We do give them to women when they're pregnant based on their BMI, and then we follow their rate of weight gain during their second and third trimester to give them some guidance. This is a pretty simple figure. There's lots of sort of complicated ways to look at this, but this is a paper from, many of you know, Dr. Xiaobin Wang's work. So this is from the Boston Birth Cohort, and this is a paper that we did with, at the time, a student who was working with the two of us, Emma Zhang, and she published this looking at, in this diverse cohort, looking at the risks of associated with overgaining in pregnancy for associated with preeclampsia, gestational diabetes, and cesarean delivery. And so the squares here are excess gestational weight gain, and you can see that the risk of having preeclampsia, gestational diabetes, and even cesarean delivery are greater in women who gained in the category of excess gestational weight gain. And then this is really near and dear to my heart. So this is a low S curve, and we're looking at the association, you can see on the x-axis, of the number of pregnancies a woman has in her lifetime that are associated with excess gestational weight gain, and then her risk on the y-axis of having excess greater than, well, you can see the curve. It's a curve looking at the midlife BMI. So more pregnancies with excess gestational weight gain is associated with greater midlife BMI. So if you have multiple pregnancies, you gain too much, then you're at risk for overweight or obesity later on in life. So this slide is familiar to many of you here in this department, and I apply it to my work also, where we can apply a life course lens, thinking about early in a woman's life course and different stages around the perinatal period when we can prevent obesity. So we're thinking about the preconception period, counseling women before they get pregnant about weight loss and reducing their weight to a healthy weight before they get pregnant. We're thinking about managing their weight and reducing their weight gain in pregnancy during the prenatal period. And then certainly postpartum and in between pregnancies, which is interconception, these are really areas that we're targeting for weight loss and to think about trying to improve their health for the next pregnancy and for their lives in the future. So there was a systematic review published just last year that was looking at interventions for healthy weight gain in pregnancy. So in clinical practice, the types of interventions that we typically do are if a woman meets eligibility criteria, we will recommend bariatric surgery. We do a lot of counseling before pregnancy, but once a woman is pregnant, it's really challenging to identify the right strategies that we should apply to help her limit how much weight she should be gaining. And so this review identified 64 randomized controlled trials, and they were all designed to limit weight gain in pregnancy. And some of the interventions were very structured, where they didn't just have a provider giving somebody counseling. And most of them were fairly intense, which means that participants had a lot of contacts with an interventionist, so somebody who was teaching them about behavior change in pregnancy. And they were mostly at least once a month, and sometimes they were high intensity, where they had what they called 12 or more contacts during their whole entire pregnancy. Most of these interventions were not remotely delivered, they were face-to-face, and very few of these interventions used an evidence-based or structured curriculum. Most of the studies recruited from prenatal care, but they weren't really connected to or integrated into these practices. So this is a very busy slide, and I highlighted at the bottom the meta-analysis of what you should take away. But they combined all of these trials into this huge forest plot and meta-analysis, and they looked at the effect of all these interventions together on mean gestational weight gain and found that if you combine all these trials, you can impact gestational weight gain by about 1 kilogram. So we do all this work for 1 kilogram. But there's also some other benefits. So we also saw that there's a decrease in risk of gestational diabetes, but there was no effect, at least in this analysis, on gestational hypertension or preeclampsia. There's a decreased risk of postpartum weight retention, which is really important because women are less likely to hang on to that pregnancy weight, and then they're less likely, hopefully, to then be overweight or obese in the future. And there's also a decreased risk of infant macrosomia. So those are the bigger infants, are the macrosomic infants, or the large for gestational age infants. But there was really no association with their risk of having early births, preterm birth, or NICU admission. So based on this huge systematic review, it was the first time that the U.S. Preventive Services Task Force reviewed this evidence, and they made a recommendation, and they call it a grade B recommendation. So grade B means that they took all the evidence, and there was a moderate amount of certainty, so moderate certainty that there will be moderate benefit if you do what they recommend. And what do they recommend? They're recommending that for pregnant adolescents and adults that we offer effective behavioral counseling interventions aimed at promoting healthy weight gain and preventing excess gestational weight gain in pregnancy. And what I love is now the U.S. Preventive Services Task Force is telling us how we should do this. So this didn't used to happen with these recommendations, but it's very useful. So they're saying the first thing we should do is figure out who's pregnant. So we have to identify those patients, and then we have to offer them effective counseling. And they kind of give all these different options. But one of the challenges is that in all of these randomized controlled trials, when the funding ends, the program ends. So even though they were shown to be effective, none of these programs were really implemented into real world care, and none of them really assessed how we do that. Like, how do we implement these into clinical practice? What do we have to do to make sure that this is picked up by a health system, that this is something that insurers will pay for? And once all of these amazing programs that were tested were completed, they all went away. And so the next step really is now saying this is important, and now we need to figure out how to implement it. So our group has been working on this for a while, even before all of these meta-analyses were done. And we were very interested in this issue of gestational weight gain, in part because of it being a risk factor for future obesity. And we had been working on weight loss trials in non-pregnant adults and learning from this trial in particular called the POWER trial that remotely delivered interventions were equally as effective as what was sort of traditionally done, which was in person, very intense face-to-face counseling and intervention. And when we started doing qualitative work and talking to pregnant women, we realized that remote delivery was going to be the way to go, because pregnant women are very busy. They have work, they have families, competing demands. They are tech savvy, even more tech savvy than these adults were in 2011 when this paper was published. And they really desired remote delivery and were able to do just as well with remote delivery, if not better. So some of our qualitative work way back when was looking at our patients here at Hopkins and having conversations with both OB patients as well as their providers. And we also interviewed many leaders to understand what we would have to do to take a trial or an intervention from a trial like POWER and change it so that it would fit with the situation of pregnancy. So we learned from patients that they were very motivated to have a healthy baby, and that changing lifestyle, if it meant that they would be more likely to have a healthy baby, they would be very willing to make behavior changes. This patient said, I just want to make sure that I have a healthy delivery. Both of us will be healthy. And of course, take care of him. I have to be healthy first so I can take care of him. We also learned that social support and having a sense of community was really important, and that they loved the idea of having a coach. So we were going with this idea of remotely delivered health coaching and asked them what they thought about talking to somebody to provide that support. And so patients said, the fact that I'm starting to see more and more people that care makes me want to stop unhealthy behaviors. And it's good to have not just inside support, but outside support, someone that is getting to know you to support you. We also asked them a lot about technology and various features that they would want out of the program. And this patient said, well, my providers will know where I'm coming from. They could work with me better. The stuff I'm talking with my coach about is big picture about what's going on with me. Sometimes I forget to ask my doctor questions, and I could ask my coach because my coach is going to call me. So we designed our intervention and then tested it with all of this feedback and designed what we're calling a feasibility and acceptability randomized control trial. So we did this in a small group of women. We had 25 women in a randomized controlled trial here at Hopkins. We used one clinical site, and they were either assigned to our remotely delivered health coaching intervention to limit weight gain, or to a health education control. And we had health coaches. They were trained in motivational interviewing. We designed a web-based program that had activities that were educational on diet, exercise, wellness. We heard a lot from participants at the time of the design that they didn't want us to just focus on diet, exercise, and weight, and especially wanted to learn more about sleep and communication with providers and with partners. And so we have a lot worked in on wellness. And then we also taught all of our participants to use a mobile application to support their behavioral tracking. So we know from weight loss studies that tracking your behaviors is correlated with weight change. And so we adapted that for our own intervention. And all of the participants used an app, and we've used lots of different apps now. So for this pilot study, we used Lose It. But usually we try to give people a free app, and then we teach them how to use it so that they can continue to use it after pregnancy. And again, it was small. It was 26 women. And one of the things that we worked really hard on is integrating all of our processes, particularly recruitment, into the initial prenatal visit, so that my team ended up not doing any of the recruitment. All of the recruitment was done by nurses who do that initial prenatal visit, or something called a nurse history visit. We had very high engagement. So this is only the 13 women that received the pilot study, but they completed their learning activities, which are online, in very high rates. They completed their coach calls, they tracked their weights, they tracked their calories, which is really hard to get people to do that. And they did not track their exercise all that much, which is actually fairly typical in pregnancy interventions. And it's hard, from our trial, it was hard to know if people didn't exercise or just didn't track their exercise that they were doing. But either way, we know that it's exercise interventions are not usually extremely successful among pregnant women, because all the pregnancy symptoms make women less likely to want to exercise. And we did see a hint towards efficacy. So you can see here, this was our coaching arm in red. And on average, at 37 weeks, women gained about 20 pounds and 29 pounds in the education arm. So this is too small to really detect a statistically significant difference, but it gave us enough of a push to apply for our next grant, because we saw this hint towards efficacy, and we had a lot of feasibility data at that point. So I'll just pause really quick. Before I jump into a trial, any quick questions?
Hi, Wendy, I have a quick question. When you're calculating gestational weight gain, are you taking into account their baseline BMI? How does that factor into this? Because I know that it differs based on their pre-pregnancy BMI.
So there's different ways of doing it. So for our trials, we're actually, because they're randomized, we do a between group difference, and we compare mean, total weight gain in one arm compared to total weight gain in the other arm. So we're looking at total weight gain. But another way that a lot of groups are doing this, and we have this as a secondary aim for all of ours, is then you can look at the proportion given their starting BMI who meet their weight gain goals. And so that would be sort of another way to look at it, where it's looking at sort of a proportion. So there are different ways people do it. And then when we assign for our intervention, like when we deliver it, the way we make recommendations is they're very individualized. So we give individualized, actually for the pilot study, it was very specific. We gave individualized calorie goals and weight gain goals for each participant based on multiple factors, but mostly related to her pre-pregnancy BMI. And then in the postpartum period, we recalculate everything depending if she's breastfeeding or not. I don't know, Allison, is that too much detail?
Oh, no, that was really helpful.
Okay.
Yeah, thank you.
Yeah. So, and Andrea, you asked about diaries and logs. I'm going to go over the current trial a little bit, and that'll give you a sense of sort of what we're doing right now with technology. But the pilot study did involve some of that, though. And then, can you look at gestational weight gain Z-scores to account for gestational age? Yeah, there are different ways to calculate it based on gestational age. I haven't seen people use Z-scores as much as rate of weight gain is probably the most commonly used way to look at that. But all right, so I'm going to move on. So we were really thrilled to have this trial funded, and I want to just share with you the mechanism because it's called an R18, and it no longer exists, unfortunately. But the mechanism, it was specifically focused on pragmatic research in healthcare settings to improve diabetes and obesity prevention and care. But what made this really challenging as a grant that we wrote is in this mechanism, they would not pay for the interventionists. So for us, those are our health coaches. Those are the people that deliver the intervention. And we designed this grant so that our coaches are part of the care team. And that has been the most challenging thing, particularly because we were funded in May of 2020, which is right when COVID started. So I also want to share with you the rationale for pragmatic trials. So this mechanism was all about pragmatic, and the reason that NIH has been very interested in this is that there is concern that we get all these results from trials, but they don't tend to inform what we do in clinical practice because they're optimized to determine efficacy. And we know that efficacy trials could overestimate benefits and could underestimate harms. And so it's really important now that when we have programs that are potentially going to be useful for clinical practice, we design them in ways that are most emblematic of the way they're going to be implemented into a real world environment. But it is very challenging to do that with the rigor of a trial design. So that's the balance. And so pragmatic trials are really designed to see, does it work in a real life condition as best as you could figure that out? And then they can inform clinical or policy decisions because then you're providing evidence about why it worked or why it didn't work in that real world setting. So we use a guide based on the PRECISE 2. So this is a pragmatic explanatory continuum summary. That's the PRECISE. And they've published a lot in this area, but I wanted to just show you that it's a way it gives us a tool for highlighting and thinking about what are the features of our study design that will enable its real world applicability. So there's this nice little wheel that you can look at, and I'm going to go through some of these, but an example here is eligibility. So really thinking about who is selected. Are these real world patients? How are participants recruited? What's the setting, the organization that you're implementing it into? How flexible are you with intervention delivery? How are you measuring or looking at adherence? How closely are you following participants? The primary outcome, is it relevant to patient care? Is it patient-oriented, things that patients care about? And then the primary analysis, you have to make sure you use ITT, intention to treat analysis approach so that you're including all of your data. So the first thing that we thought about was really effectiveness, right? So we designed a trial that's going to look at the effectiveness of Healthy for Two, Healthy for You. That is our intervention on gestational weight gain. So we're doing a lot of screening with the goal of randomizing 380 pregnant people to intervention, which is Healthy for Two, Healthy for You, versus a usual care control. And we call this the MHIP, or Maintain Health in Pregnancy arm. Our participants are followed through delivery, and we have 6 months after delivery outcomes in both the mother and the infant, and all of our follow-up is leveraging Epic, which is our electronic health record, and then we also have some in-person contacts that we do. So this is the design, this is the flow for our pragmatic randomized controlled trial. The primary outcome is gestational weight gain, and this probably gets to your question, Allison. So we calculate this as the 37-week weight minus their baseline weight, which is assessed at less than 15 weeks gestation, which is identified at their very first prenatal visit. So if somebody presents for care at 18 weeks gestation, then they are excluded from our study because we do not have that early pregnancy weight. And this is actually one of our challenges, is making sure that we're both inclusive, but that we can calculate our main outcome. Our secondary outcomes have mom outcomes and infant outcomes. So we're looking at gestational diabetes, postpartum weight retention, and then we have infant growth outcomes, birth weight, and weight at 4 and 6 months. And the overarching hypothesis is that women in our intervention arm will have lower gestational weight gain and lower rates of gestational diabetes without an increase in low birth weight infants. And then I'm going to share with you a little bit about the implementation, but that implementation into prenatal care clinics will be scalable and will be feasible and potentially scalable. So the implementation aim for this is that we're also assessing the organizational factors that impact implementation into prenatal care. So we're looking at how we deliver the intervention. We're looking at provider staff satisfaction. So we're doing interviews and we're doing a cost analysis. So I wanted to share with you some of the considerations using these PRECISE domains that I shared with you about how we have to design our trial. So the first one, the PRECISE domain, is around investigator and study participant selection and engagement. And this really means that we need to look within about our investigator team so that we have a mix of experience appropriate to this intervention. And we need to involve clinicians, so on the ground clinicians. And, you know, for me, this actually has been such a great opportunity to really understand how prenatal care works, to talk to lots of our nurses, our nurse midwives, our OB providers who are delivering care on a day-to-day basis. So we've done a lot of stakeholder engagement. We've had a lot of advisors telling us what to do, what not to do. And then when we have been ready to implement, we sit one-on-one with everybody in all of our clinics to talk to them about how to make this happen in real-world practice. The next issue is really about participants. So we have to have broad participant eligibility. The typical ratio for randomized controlled trials is really a 10-to-1 at the analysis phase. So our goal is to have many patients that we identify as potentially eligible get into our study and to really reduce barriers for recruitment and enrollment into the study. So we designed these eligibility criteria to really think about to what extent are the participants in our trial similar to those who might receive this intervention if it was part of their usual everyday care. So if it was being offered to them in their prenatal care clinic. And it's important to note that we're really targeting overweight and obese women. So these are women with a BMI greater than or equal to 25, which in our population of Hopkins, we estimated that to be about 50 to 60% of all patients. Age is 18 or older. And they had to have one fetus, so we were excluding women who had known 2 or more fetuses. And again, they had to have a recorded weight in EPIC early in pregnancy. For this trial, we were only able, because of budget constraints, to include English speakers. And for our next trial, we will have everything translated into Spanish. And then the major exclusions were really thinking about, like, what would we have to do differently for intervention implementation that we're not ready to do yet? And this is really women who came in with pre-gestational diabetes diagnoses and who had sort of complications related to prior pregnancies, like very preterm births, or coming in with poorly controlled blood pressure, not being able to walk because they were very short of breath at their first visit. So you can see that most of these major exclusions were things that are rare, and for the most part, we're trying to include as many women as possible. So we are also trying to make the consent process easy. And this is actually really challenging because you want to have a balance, right? You want to make sure that participants understand what they're getting into, that this is research, but at the same time, you don't want there to be so many barriers that they end up not being able to participate. So we've designed our recruitment process and actually our subsequent consent process as much as possible to emulate real world clinical practice. So the way this works right now is that if you are an OB nurse in clinics seeing patients for your nurse histories, this best practice advisory is built into Epic and it pops up. And it says your patient might be eligible for this study. And it gives them enough information that they could suggest to the patient whether the patient might want to join. And if they click yes, potentially eligible, then it gives my team the ability to review whether the patient is eligible using some basic eligibility criteria in Epic. And then if the patient is eligible, my study team reaches out. We schedule a video call for the patient, and all at once we can screen them for eligibility, make sure they continue to be interested, and do a consent, all facilitated through video and also REDCap. So REDCap is a tool we have here at Hopkins. Many of you have probably used it, but my team's really skilled right now in designing these electronic consents into the REDCap electronic platform. This is what our consent process looks like. And the way it works is that someone is on the phone walking them through what they're looking at on a screen, whether it's their phone screen or some other screen that they have up. Once they consent, we send them lots of information, including their consent form about the study. So the next domain is really thinking about the setting and organization. So how different is the setting that we're using from where they would normally be getting care? And that's why we've really embedded this study into routine care. And as much as possible, we want the patients and participants in our study to feel like this is part of the care setting. And so we communicate with our providers. We send provider progress reports to providers, and we really want to think about, the feasibility. What makes our intervention hard to deliver is what I mentioned at the beginning, which is that our coaches need to be part of the care setting too. And that's actually been the most challenging thing, because there is no existing role right now in the healthcare system for a health coach. And so we've really worked within our system to create this new role. So these are our partners. We work with Johns Hopkins Community Physicians. We work with Baltimore Medical Systems, which now owns East Baltimore Medical Center, which used to be part of Hopkins. We work with Bayview, which has 2 practices at the Bayview Medical Office, as well as White Marsh. And then we have Nelson 2 and Jayhawk right across the street at Hopkins Hospital, and then Green Springs Station. So in terms of the delivery of our intervention, I'm going to share with you a little bit more about the intervention, because I haven't shared much about what we're actually doing, and I know there were questions about this technology. But the idea of intervention is really designing something that can be delivered potentially as normal routine care. And that is really hard when it doesn't currently exist at all in normal care. And so as much as possible, we've been considering trying to be as flexible as possible with the intervention, both in terms of participation, but also how we engage with our different clinics. So let me share with you what the intervention is. So it's all around promoting healthy lifestyle in pregnancy, and we have very much a focus on how much to gain in pregnancy, but we also have the wellness components on sleep and mood and stress. So it has these 3 components. Participants who are randomized to intervention are assigned immediately to a health coach. All of their health coaching happens by phone. They also have access to our interactive web program, which has all their educational materials. And then right now, we're using Fitbit for their mobile app. Although if a participant says, hey, I've been using MyFitnessPal or Lose It for a long time, can I use that one? We are app agnostic, and they can use whatever app they have used before. Our health coaches are existing clinical staff. So for this trial right now, we have 10 trained health coaches. We have nurses, dietitians, medical assistants. We even have a medical office assistant who's like our registration staff member. So they receive training from our team on motivational interviewing, on how to deliver the intervention, and then we monitor and supervise them closely. And then participants do all of their web-based learning activities that I mentioned, and right now they're tracking their weights using Fitbit. So this gives you some quick screenshots. We use something called the COACH model for our intervention. So COACH stands for commit, omit, and limit, add, communicate, and honor your wellness. And these are the behaviors that we target. So we focus for commit, we focus on committing to yourself, committing to the program. Omit limit is very diet focused on trying to omit certain things and then adding in more like vegetables, exercise, communication with coach, provider supports, and then honoring yourself and your wellness. These are our core learning activities up here. Those are the first 7 are the topics, but we actually goes all the way through 19, and these are the ones that are in pregnancy, and then we have a few more that we do postpartum. As I mentioned, we try to connect with providers as much as possible. These are epic snapshots. So when a participant is enrolled, we put in their chart something called a patient care coordination note. This is our dietitian who works with us, Christine McKinney, and she puts this in telling them that this patient is enrolled in the intervention, who their health coach is, who our project coordinator is, that I'm the PI, so that the provider can reach out if they have any concerns. And then we put progress reports in. So here's one on a participant to date. She's completed 57% of her coach contacts, 21% of her learning activities, and tracked her weekly weight 69% of the time. So we give them a sense of how the participants are doing, and then we give them some tips on how they can help their participants do better. For follow-up for data collection and outcomes, we are using lots of tools. So we use surveys using REDCap, so those are electronic surveys. Ultimately, the goal is really to reduce burden. So we do this all by email. And then we are getting a lot of data from Epic. So we have a constant flow now of data coming into our trial from Epic. And this mostly is focused on when people have prenatal visits and what their weights are at those visits. We also are able to assess safety outcomes. We get alerts every time someone shows up in the emergency room or in the hospital. And then we have some other data collection. So we do try to get one in-person height and weight during pregnancy, and that's actually mostly to verify their height, because in OB care, height is more often than not self-reported. And so it means that you show up to your visit and someone says to you, "How tall are you?" And they put that in as your height. So for this study, where we're really interested in body mass index and we're really interested in tracking that over time, we want at least one accurate height. Unfortunately, height doesn't usually change when people are pregnant, but we try to get that at a 24-week visit, and we show up at their usual prenatal visit. We also have been doing some refreshes in clinic on the importance of measuring pregnancy weight and height to make sure that we're getting research quality measures in clinic as much as possible. And then we've designed a collaboration with the pediatric care providers so that they're also measuring mom's weight at the infant well-child visits that occur in the 6 months after delivery. And shout out to Josephine, I think she's here. Josephine has designed this wallet card. And this is a card that prompts the recording of mom's height and baby's information at their pediatric follow-up visits. And this way mom can also track it. And also we can then get this information from the participant. We have them enter it into their REDCap survey. So this gives you sort of a sense of all the different tools we use. So again, we use Epic. We've designed this flow. We use something called CRMS, which is probably going to be changing here at Hopkins, but it's a safety surveillance tool. And then we can also use this constant flow of data to figure out when data is missing. So we rely on Epic to bring us the data, But when we're missing weights, like if mom stops showing up for care or she moves to another clinic, then she's still enrolled in our study and we can arrange home visits when we identify that there are missing weights. So endpoints. So we knew that our endpoint was very clinically relevant. So we're looking at total gestational weight gain. It's important to patients. It's important to providers. The challenge of all this is really the missing information. And what's great about using EPIC is that we're able to get all pregnancy weights from first prenatal visit to last. And so we will be able to have a constant trajectory of weight gain in pregnancy for all of our patients that continue coming to Hopkins. The challenge is when patients either stop coming to Hopkins and we don't get their data, which is when we do home visits, and then in the postpartum period where we're very worried that the data is at greater risk for being missing. We are doing an ITT or intention to treat analysis using a standard mixed effects model, and that will be the final analysis. I also just want to share for some of you who are very interested in cost, we are doing a cost analysis. This is led by Emmanuel Drabo in Health Policy and Management, and we're looking at return on investment from the perspective of an adopting organization or payer. So we're thinking about this question of what would it take for a payer like Medicaid to cover our program if it was part of care? The other question is, what would it take for a health system that cares about patient outcomes like Hopkins to incorporate this into care? And so we have to determine the value, and we're using some claims data. We're calculating costs of intervention delivery, all the human resources, the intensity of intervention, the costs related to our website. We're getting a lot of stakeholder input. What is high value for payers? And then we're also asking our participants about out-of-pocket expenses. And some of the things that we're thinking about is like if somebody starts exercising and they had never exercised before, did they now have to go, buy a gym membership or start getting better sneakers? Or what were some of the costs that participants now had as a result of being in this intervention? So before I take questions, I just want to share with everybody a new project that we have, and many of you are working with us on this project. So we were fortunate that within this newly funded Mid-Atlantic Center for Cardiometabolic Health Equity, which is being led by Deirdre Cruz and Lisa Cooper, that there are three research projects being funded. And Kelly Bauer, who is a School of Nursing faculty member, and that's her picture there, is leading us in an effectiveness trial, so another pragmatic trial, looking at our health coaching program that is being tweaked a bit, and it's focused on reducing cardiometabolic risk among women and infants who are enrolled in early home visiting services. So I know this home visiting is near and dear to the hearts of many of you, and I am certainly learning a ton from Kelly and from others about how to do this. And we are currently taking Healthy for Two, Healthy for You and translating and adapting it into Spanish. And we are also figuring out how to make it fit into early home visiting service delivery. So this is our big next step. We just got funded, so we're just launching this. Hopefully we'll launch by the late summer. So I want to thank our team. We have this amazing, amazing team, which makes my job easy, but also fun. And this is a really fun project. And I especially want to thank Dr. Janelle Coughlin, who has designed and led our intervention now for over 5 years of work. And then I have multiple co-investigators who are in OBGYN as well as in pediatrics. And we have a biostatistician, Dr. Wong. As I mentioned, Dr. Drabo is leading our cost analysis. And then we have this really incredible research team. And I want to highlight two of our research assistants who are here in this department, Josephine Pites and Nikita Patlala, who are fabulous and have now worked with us for about a year or more. And so it's really an honor to have such a great team working together. So I'm happy to take questions. And I think Let me see if there were any in the chat. Okay, so Susan, I'll read your question unless you want to read it.
You can go ahead and read it.
Okay. So have you thought of following this cohort through to their next pregnancy? One of the policy changes being considered for WIC is to extend women's participation to 2 years postpartum to cover the inter-pregnancy period and improving pregnancy outcomes for the next pregnancy. So that's a great question. And that's actually sort of near and dear to my heart, is understanding what happens weight trajectory wise to the health of our participants and their infants through their lives. So we have built into this the ability to follow them as a cohort in EPIC. So that will be more passive surveillance. So for those who continue getting their care here at Hopkins, we will continue to have access to them as a cohort to follow their care experiences, and their weight trajectories. It would take additional funding, however, to be able to more actively follow them in terms of doing follow-up surveys or show up at their homes and collect more data. And then we would need to apply for additional funding to do anything more than sort of that passive follow-up.
Wendy, such a fantastic talk. And I see Erin's comment in the chat. I want to especially open it up to students who may have questions to feel free to either add them to the chat or raise your hand or come off mute so you have a chance to ask your questions.
Yeah, I'm happy to answer questions. And I also want to ask, Andrea, did I get to your question about the food intake and exercise and the diaries when I talked about the intervention? I want to make sure that it got to sort of the root or depth of your question. Okay, thanks.
Wendy, as other questions are coming in, I was wondering if you might be able to comment on sort of the process of adapting the intervention to use in conjunction with home visiting, and what some of the opportunities and challenges, might be for that.
Yeah, so that's a really good question. So we designed the next trial with a lot of feedback from home visiting leaders that home visitors are extremely busy, and that it would be hard, at least initially, to have them do any data collection or any intervention delivery. So those parts are going to be all done by the study team. What we are really hoping to get their assistance with is identification and enrollment, and working with processes that they already have to make that very easy. And we are also working through sort of to make it so that they don't have to share any data with us. And so what that means is there's so it turns out, and you probably know this better than I do, but the thing that we're actually working on now, and this could change in a month or two, is doing a lot through text messaging. So when a home visitor for the first time is meeting with, whether it's virtual or in the home with a new client, then there's this opportunity for them to exchange text messages. And we're hoping that one of the text messages would be something like, here's some information about this study, and it would be explanatory. And if you're interested, press here. And then we would sort of take it from there with our process and form. But that if the home visitor encourages them to consider it, that would be their way to get enrolled, without asking the home visitor or this home visiting staff to give us lists of potentially eligible participants, which is going to be probably challenging because they won't have all the data at their fingertips, and getting them to run data for us will be burdensome. So we're looking for sort of low burden solutions. We're also going to do a fair bit of training, a lot on healthy lifestyle. As you know, many home visiting programs are already doing motivational interviewing. So, we're not planning to do anything like that, but we're going to do some training on supporting health behavior change. I'm curious to hear, Cynthia, what you think about this, because this is still, we're just starting to meet on a regular basis with the home visiting programs.
So yeah, so I think your first point about home visitors being so busy already and having so many data reporting requirements are what it led me to ask. And so I think figuring out a way where they can give you a linkage to interested, participants, but without putting the burden on them to do much more beyond that is probably going to be the most sustainable. So it's a huge challenge because the ask for home visitors is so large.
Yeah. Thank you.
Other questions that folks have?
Yeah, I'd really be interested, Cynthia, once you start working with the Enrich sites, hopefully, fingers crossed, or once we know more about who those Enrich sites are, I should say, then for us to figure out sort of what are some of those processes, even if the way they're doing things are different, like their intervention or their sites are different, but just understand like what are some of the common processes around enrollment that, like you said, are sustainable.
Yeah, I think it should be really interesting with a lot of shared learning. So hopefully we'll be in that position relatively soon. So we'll see. We'll see. I guess another question to ask if others aren't jumping in is, COVID happened right as the first, project was getting started. It seems to me like there's some things that came out of your work that maybe you wouldn't have gone down that path had we not had a pandemic. And I was wondering if you want to highlight any of those in ways that a lot of innovation happened that perhaps wouldn't have happened otherwise.
Yeah, so a couple of things. We were really fortunate that we had already designed so much to be remote. So we had sort of remote consent. We have remote, our screening process is remote, consent process, and the whole intervention was designed to be remote. And we had already tested it as a remote delivery platform. So programs that had to suddenly switch everything they do from in-person to remote, I think was hard. We did not have that because ours was already already up and running that way. Where we had challenges was really around getting the right level of engagement from the health system. And that was partly, as everyone knows, staffing in clinics has been really fluctuating, and there's been so many absences, and there's been a huge amount of staff turnover. So just as soon as we train one of our coaches, then that person leaves. And also our coaches are actually donating the time to this program. So that means that their supervisors have said, we value the time that you're spending on this project. You can do it for 1 hour or 2 hours a week. And we're going to make that happen in your work life, and you can do that as part of your regular schedule. And so for us to get that level of support and buy-in took a long time. And the fact that there was COVID happening at the same time, and there were so many demands being made on clinics, and one of our clinics is still not there yet. But the rest are. And even with all the turnover, we regularly go in and meet with them. And we've designed so many of our systems now to make it really easy for them to refer patients in. And then I would say that the most exciting thing is when our coaches reach out to us and tell how much they love being a coach. And I think that's been sort of the lesson that I learned from all this is I didn't realize how much the coaches would enjoy that level, because it's this connection with patients that they don't normally have, and that's 20 minutes and that phone call. And a lot of nurses and dietitians really went into healthcare to have those connections with patients, and they were missing that. And actually the support that they now get from their supervisors to continue with this, I think that's been sort of the biggest lesson. We get little notes from them about how much they love being a coach, which I just think is really cool. So we have to tell that story. I haven't figured out how to tell that story yet, except to say, I'm so glad that you love being a coach, and we value you too, but we have to capture that, because I think that's been really cool. And that's something we have to tell, in the era of really thinking about how we support our staff in their wellness and in their career goals. I think that's something, when we communicate that to them, the value of a program, that's a piece that we have to make sure we include as sort of that humanistic part of this.
Yeah, that's great. So thank you for sharing that. It's really interesting. We often think of unintended consequences as being all the bad things that happen. So it's really nice to elevate when there might be a contribution unintended related to, well-being of staff and burnout. So thanks.
I think David has a question. Go ahead, David.
Yeah, thank you. Am I unmuted? Yes, thank you. It was a really fantastic talk and great work. So thank you. You conjured up parallels of what we did with peer counselors. And one of the problems we had was trying to assign, because our participants did not go to every one of the coaching meetings. I love the term coaching, and it was difficult to assign outcome given the range of participation and also timing. Although you've solved that with 15 weeks, I was particularly impressed with the Epic having the information with how much they participated. How so? The question is, how are you going to deal with the difference in participation on the part of the clients, and also in terms of disease or morbidities that will surface throughout the pregnancy, particularly preeclampsia, that will influence your weight also. So my real purpose is to look at you in awe that you were able to accomplish so much. So thank you.
That's very sweet. Thank you. Yeah, so the first one is really around adherence, right? Like how will we measure it and how will we take that into account? And then the other is sort of what are some of these other clinical outcomes that matter and how will we look at those? So in terms of adherence, adherence is always really tricky with behavioral interventions because we don't really understand dose. We don't understand, and dose, what works for one person might be really different than what works for another person. And that is actually the biggest challenge of doing behavioral interventions is understanding that. And so, we will measure adherence and we have lots of measures of it. So, because we look at sort of how many coaching calls they make, we look at, and these are kind of counts, right? So and we do a little bit about quality. So we're also asking participants, like, tell us about your relationship with your coach. We are assigning one coach to one participant. So that's really lovely. And we actually put a lot of thought into who we match. So that they can have that connection, and then we will ask them about how that went. And we haven't had a situation yet where like it was a bad match, but we will probably have that happen and be able to change people around when needed. But we will measure adherence, and I'm sure we will do some non-mean analyses, sub-analyses looked at among people who have lower levels of adherence compared to those with higher adherence. What were differences in their outcomes in terms of the main outcomes? So I think we'll probably have some other papers that'll come out that'll look at that, because I think that's a really good question, and that can get at some of these things. And the people that care the most about dose, of course, are payers. Right? So they want to know, like, what's the least number of contacts you can do to get the right effect? And that's because it costs more if you do more contacts. And that's the challenge, right? Like, what works? And a lot of trials are being designed now with these sort of like, varying dose and like, and getting re-randomized, and they're really tricky to design those studies. So, we haven't done that, but I think we're sort of thinking about these adaptable designs in a way, like how would we do it given the sort of behavioral work we do? The other question you had about the other outcomes, and I'll just say, so we obviously haven't unblinded, we haven't looked at our data yet, but I do all of our safety monitoring with our team, and we have very high rates of complications and so I don't know which group they're in, but this is not this is a sicker population of pregnant women here at Hopkins and in our practices, and they all have overweight and obesity, and so we have lots of hypertensive disorders. We have lots of preterm birth. Preeclampsia is extremely common. NICU admission is very common. And so we are measuring all of these things, and we will be able to look at it. And I think that'll be really important to understand. We don't have hypotheses about this, but this is also where payers, health systems do care, and they care a lot about NICU admission as they're, to say that doing a behavioral intervention that helps with gestational weight gain is going to impact NICU admission, I think is a stretch, but we'll definitely look at it.
Thank you. Terrific.
I just really want to thank you, Wendy, for an outstanding talk and conversation. But of course, this means we're going to have you back to give us the follow-up story of what is actually happening. So we're looking forward to staying closely connected and to next steps. So on behalf of everyone, just really want to thank you for an outstanding seminar and for being such a wonderful colleague.
Thank you. Thanks
so
for
much.
having me. And it's great to see so many friends. I didn't get to look at all the names, but it's great to see all of you guys.
Great. Take care, everybody. Thanks for joining.